So we will discuss here two of the fat-soluble vitamins, vitamins E and K. Remember that there are four fat-soluble vitamins, A, D, E, and K, and then the two water-soluble vitamins, which are the B class and C. So vitamin E is a group of fat-soluble chemicals that serve as antioxidants in the cell membrane, and is really actually a mysterious vitamin because we don't know exactly all the things that it does, and there are a lot of studies going on as to what the therapeutic potentials are of giving vitamin E in various scenarios. But the really interesting fact is that it is an antioxidant, and so we're looking at a lot of these antioxidants as possibly being able to prevent cancer or being able to prevent atherosclerosis, but these studies are still ongoing. But we do know that it is a component in many cellular membranes existing within the cell membranes, and it stabilizes the cell membranes. So if there is oxidative stress from reactive oxygen species, it won't hurt the cell membrane. We also know that vitamin E inhibits platelet aggregation to some extent, and the reason we know this is because patients who are overdosed on vitamin E actually have a propensity to bleed. And then it's also been proposed that vitamin E has an inhibitory effect on HMG-CoA reductase. And so that's really interesting as far as when we're thinking about patients who are deficient in vitamin E, what that might mean. Vitamin E is considered to be neuroprotective. It is neuroprotective in as much as that the neurons really require a stable cellular membrane. And so when we're talking about vitamin E deficiency over a prolonged period of time, there tends to be damage to the cerebellum and the posterior column. Vitamin E members are primarily found in oils and margarine. So the oils that it comes up in are wheat germ oil, sunflower oil, olive oil. Olive oil is very common nowadays in the American diet. Also nuts and nuts themselves. And then it also exists in leafy greens. So when you look at the average American diet, what people eat, vitamin E is pretty common. So we're not looking at a deficiency in this vitamin in the general population. It's not common, as opposed to maybe vitamin D, where we don't see vitamin D in most foods, and so vitamin D deficiency is much more common. Vitamin E deficiency in a healthy person eating the average diet is extremely uncommon. So these are some of the things that you might see vitamin E in. And so vitamin E deficiency is going to be seen most commonly in two populations. So number one, we will see them in premature infants. And the reason for this is that there's a big vitamin E transfer that occurs in the last weeks of gestation. And so the babies who are born a few weeks early, or even earlier than that, they miss out on that. And so they're going to have much lower vitamin E stores in their body, and so as they're developing new blood cells, they're not incorporating vitamin E into those blood cells, and so they have a tendency to develop hemolysis. And then malabsorptive patients, any patient who has issues with fat absorption, because this is a fat-soluble vitamin, they're at risk for vitamin E deficiency as well. So when we look at the infants, the premature infants who have vitamin E deficiency, the one thing that we primarily see with them is hemolysis that develops not right away after birth, because a lot of their blood cells have developed in the setting of the mother getting vitamin E. But the problem is once the vitamin E stores that they have are exhausted, then they're not going to be able to incorporate vitamin E into their red blood cells. So once those red blood cells without the vitamin E develop, they're more fragile and they're susceptible to hemolysis. So they can develop a hemolytic anemia. They can also develop thrombocytosis and edema. I'm not exactly sure why the edema happens, but it does. So this really underscores why it's important to give a particularly special formula to premature infants. And the formula that's given to premature infants is low in polyunsaturated fatty acids. And you might wonder why that is. If you just look at it on the face of the formula, why is it low in polyunsaturated fatty acids? Well, these fatty acids, polyunsaturated fatty acids, are a little bit more fragile. And so if an infant is getting these polyunsaturated fatty acids, well, that's fine if they're incorporated into cells that have vitamin E, because the vitamin E is going to be protective. But if you have a child who's low in vitamin E, and then they're incorporating these polyunsaturated fatty acids into their cells, you now have two issues. You've got more fragile fatty acids as part of the cells, plus you don't have the protection of vitamin E. And so this is really going to make these cell membranes more susceptible to oxidative damage. Now, when we talk about the malabsorptive patients, these are usually a little bit older, then we have a prolonged vitamin E deficiency if they're not being treated, and ultimately this can lead to permanent damage to the central nervous system, particularly the posterior columns and the cerebellum, and even possibly the retina. So the neurologic manifestations of this, when we look at the posterior columns, there's going to be a reduced deep tendon reflex. That's usually the first thing we see when we're screening children. When they come in for their well child visits, reduced deep tendon reflexes is something to think of, particularly in children who are already malabsorptive. If there's reduced deep tendon reflexes, then we start to get concerned about vitamin E deficiency. Also, loss of vibratory sensation, that kind of goes in with the posterior column defects, decreased proprioception, and then a wide truncal ataxia. Generally, what that looks like is the child is walking, has a wide-based gait, and they're usually looking down at their feet, and that's because they have both the decreased proprioception and cerebellar deficits. Dysdiadochokinesia, that's a nice mouthful of a word, but this is the ability to do repetitive movements. So good way to test this is to have a patient touch their thumb to each finger and to just repeat that and go back and forth. And then intention tremor, nystagmus, ophthalmoplegia, and blindness are things that you can see a little bit later on. So these are the neurologic manifestations. And this is prolonged vitamin E deficiency. So a premature infant is not going to have neurologic deficits. They're going to have these more acute deficits with stability of their blood cells. So this is just a schematic of what happens and what vitamin E does. So you have reactive oxygen species, which happen in all of us, and we have ways of protecting our cells from that, and vitamin E is one of them. So if there's membrane disruptions, you can have membrane repair. Vitamin E also is an antioxidant, so it helps that way. But if there's deficient vitamin E, then you can get failure of repair. You're more susceptible to oxidative stress, and the cells can die. This is an example of that wide truncal ataxia that you can see in people who are who've been deficient in vitamin E for a long period of time. The way you work this up is a CBC with smear. You should get a metabolic profile. Serum bilirubin is useful, particularly when you're looking at infants. Then you can get tocopherol levels, and tocopherol is just the primary vitamin E chemical. Other tests that you can get are anything that's based on clinical suspicions you might have for underlying cause. So generally we're talking about malabsorption here. So Crohn's disease, cystic fibrosis, celiac sprue, any of that stuff, and then consideration for other nutritional deficiencies. So particularly when you have people with malabsorption, they may be deficient in other vitamins. The management is going to be vitamin E replacement. If this is somebody who's malabsorptive, you can give it parenterally, and then management of the underlying cause. Hypervitaminosis E is rare, but this is something that you might see in somebody who is taking lots of vitamins and they don't realize that you can overdose on vitamins. A lot of people seem to think that if you can get something over the counter, you can take as much as you want of it, or vitamins aren't medicine, so you can take as much as you want of it, and the more you take, the better off you are. Well, that might be fine for B and C because your kidneys can get rid of it. But A, D, E, and K can be stored in the fat, and so those are much more problematic. So high levels of vitamin E can interfere with vitamin K, and that can cause bleeding issues, as we mentioned, particularly patients who are already on anticoagulants. Vitamin K is a group of fat-soluble quinone-based compounds, and these, as you probably know, are intimately involved in the coagulation process. And what vitamin K does is it is a cofactor in the carboxylation of glutamate residues that exist on the vitamin K dependent factors, which are 2, 7, 9, and 10. So if you don't have sufficient vitamin K, you're not going to be able to convert these factors into factors that can actually function in the coagulation cascade, and so you're going to have a propensity to bleed. I'll show you a picture of this that might help you understand that biochemical process a little bit better. Also, vitamin K is quote-unquote inhibited by warfarin. It's not actually, in a strict biochemical term, inhibited by warfarin, but the process of vitamin K recycling is inhibited, and so warfarin is going to reduce your vitamin K levels. And so that's how it's given to anticoagulate. Inhibits it lowers your levels of vitamin K. Deficiency of vitamin K is primarily seen in newborns, and the reason is because newborns lack the flora that synthesize vitamin K. So we get a lot of our vitamin K not just in our diet, but also by the bacteria that exist in our gut. They can synthesize vitamin K. So even if you don't get sufficient vitamin K in your diet, those bacteria can make vitamin K for you, and it can be absorbed, and you can get enough to get by. Now, newborns don't have those bacteria yet, and so if they're born without sufficient vitamin K, then they're at risk because they don't have those bacteria yet. Remember, also, just as a side note, that the colon absorbs only 2 things, and vitamin K is the second one. Water is the other one, of course. Malabsorptive states, particularly those that affect the terminal ileum. So the terminal ileum absorbs about 80 to 85% of all the vitamin K that you absorb. So some of the things that particularly affect the terminal ileum would be Crohn's disease, if it is there, so Crohn's ileitis. And then people who are on warfarin, of course, they're going to be at risk for vitamin K because the recycling process of vitamin K is inhibited. Vitamin K, as you probably know, is notably found in the high-quality green vegetables. So this is where you see vitamin K. Kale, Swiss chard, parsley, broccoli, also spinach, So this is what warfarin does, and it's good to know this because we give warfarin out. So here you have vitamin K as it exists in its active form, and what this does is it allows a protein to be carboxylated, and so when those vitamin K dependent factors become carboxylated, they can then go and work. But until then, they really can't serve any function. So once vitamin K accepts or does the carboxylation with the enzyme, it then needs to be recycled. And it's recycled by two enzymes, but warfarin inhibits those enzymes. And so you can't get back to the vitamin K that is supposed to then go back and help carboxylate and activate those factors. So vitamin K deficiency in children and adults, deficiency is pretty rare. Generally, even if we don't get enough vitamin K in our diet, those bacteria can make enough vitamin K to get us by. But if there is, for some reason, a deficiency of vitamin K, and a possibility where you may see this vitamin K deficiency is if you've taken broad spectrum antibiotics. That can be a big problem, in that you can kill those commensal bacteria, and so in that case you may see vitamin K deficiency. And so there you would see it typically as just a propensity to bleed. Generally, it's not severe, very severe bleeding. It'll just be nosebleeds, bruises. Menstruating women will maybe develop menorrhagia. But for the most part, if you're not taking any anticoagulants like warfarin, you're not going to develop a vitamin K deficiency, except for maybe if you're taking broad spectrum antibiotics or something like that. More severe cases of vitamin K deficiency are pretty much limited to patients that are on warfarin, and so if there's a severe deficiency, you can develop more problematic bleeding, such as GI bleeding and hematuria. In infants, it's a little different. So infants can be born without enough vitamin K at birth. So remember that infants don't have their full intestinal flora, so they're pretty much reliant on whatever they get from the mother. So there's two ways that can show up. At birth, they can have bleeding due to maternal medications that interfere with vitamin K, so that could be something like warfarin or phenobarbital or dilantin. Then in the first 2 weeks of life, they can have bleeding due to poor stores of vitamin K, either due to inadequate transfer across the placenta, if mom didn't have a whole lot of vitamin K while she was pregnant, or if the baby didn't get prophylactic vitamin K, or also just the plain fact that baby doesn't have a full range of intestinal flora to commensurate and make that extra vitamin K that gets us by, usually if we're not getting it in our diet. So it's not very common in the U.S. to see vitamin K deficiency in infants that much anymore, because we administer vitamin K prophylactically after birth, generally within the first 24 hours, to reduce the risk of these issues. But if we do see it, it's usually at birth, secondary to the maternal medications. You may see it later on. So if a baby is breastfeeding, mother needs to be getting enough vitamin K in her diet so that the baby gets the vitamin K through the breast milk. If the baby's on formula, generally it's not going to be a problem because all the formulas that are given here are fortified with appropriate amounts of vitamin K. So you don't see this that often, but what I want to stress is if there is some kind of bleeding problem in the baby, some of the ways that you can see it manifested is when the umbilical stump, if you see bleeding there, that may point you towards that, or if there's bleeding at the circumcision site. Now, usually when you see these bleeding disorders, you might be thinking more hemophilia, but it's always important to keep vitamin K deficiency in mind. And also, if there is a baby that has abnormal bleeding or excess bleeding, always consider the fact that this baby may have an intracranial hemorrhage. Symptoms from intracranial hemorrhages may not manifest until there's something really bad. So it's very easy to do a transcranial ultrasound and to look for any problems before it gets worse. So the workup for vitamin K deficiency, you get a CBC, a BMP including liver enzymes, and you might wonder why you need these things, but it's helpful for a differential. You want a PT and APTT, but if you're going to just get one of them, definitely get the PT. Plasma fibrinogen and a cranial sonography in infants. So our differential is disseminated intravascular coagulation, DIC, and that is not uncommon in preterm infants, or really in any infants that are otherwise sick. What we're going to see in DIC that we don't really see in vitamin K deficiency is a thrombocytopenia, an elevated D dimer. You can have also a low fibrinogen, and that generally we don't see in vitamin K deficiency. You can also see sepsis or hemodynamic instability. Again, that's not going to be something that you see in vitamin K deficiency. With liver failure, you'll see elevated liver enzymes. And then in hemophilia, which is an important differential, this is something that you should consider in older children who have an appropriate diet and there's no suspicion of malabsorption, or in infants who you suspected vitamin K deficiency and you gave them vitamin K but they're still bleeding, or if you gave them prophylactic vitamin K and they bleed. Then in that case you can get factor levels, and that's a pretty easy diagnosis. Your diagnosis ultimately is going to be based on the history and the elevated PT that then resolves with administration of vitamin K. And then please note that the normal PT range varies by age. I would expect on the USMLE, if you're given something like a child with vitamin K deficiency or an infant with vitamin K deficiency, they'll give you the normal PT range for that age. Management for deficiency is replacement. If there's really severe bleeding, like GI bleeding or GU bleeding, then you can give fresh frozen plasma, and then you can do a hematology consult or a GI consult if necessary.